next year. So what the Collaborative Governance and Community Engagement Committee asked me to speak about was, what are we doing this year? What are all the activities that we're involved in this year? And so I'll go through, I'll go through this list, and I'll try to do it within the time frame. Pat keeps me on time. So we'll try to go through this list quickly to try and tell you what we're doing. Our main theme is integration. We're trying to integrate the healthcare system. Most people would say that in Ontario we do not have an integrated healthcare system. We have a system with a lot of silos, lots of one-offs where organizations are working together, but overall we do not have a system of care. And so we're tackling this through individual pieces, and someone might say, well, why don't you just look at the whole healthcare system and try to change the entire system? But many experiences where that's been attempted, they find that the 2 or 3 years are spent just looking at process, and they're not getting anywhere. They're spinning their wheels. They're not really doing it. So we're going through this in bits and pieces like a puzzle, pulling it together. But each time we work on one, we're trying to make sure that it's aligned with another piece or all of the pieces. The other thing that I think that's really important, we don't come up with these off the top of our head. They come out from understanding the ministry's perspective, where the ministry is going, what's important to the ministry, what the priorities are. So there's a line of setting priorities. There's alignment with the minister, with the government, with the minister, with the ministry, and with our local needs. So we understand what the ministry wants and what their priorities are, but we're also using quantitative analysis at the local level and qualitative analysis, including engaging with you and the public and other providers to give us feedback about what are the key priorities. So we put all that together to come up with the work that we're doing. So this isn't created from a couple of people sitting in my office and saying this is what we have to focus on. Much of it is being told to us by you and your stakeholders and providers. So quickly, some of you know I like to talk about this in a lot, so they've asked me to use one slide to talk about this, but why are we talking about integration? Why are we talking about transformation? Why are we talking about change? Well, there's two things that are driving this whole issue. One is the changing demand and the need for a different response. We do not have a healthcare system that's designed for the patient today. It was designed for a patient before that would have an acute care episode, would come in, leave, and may never come back for that same issue. Now, typically, patients are older, frail, more frail, have multiple chronic diseases, and will have them for the rest of their life, and will have the need for a number of component parts of the healthcare system to really assist them. Those component parts have to work together. We don't really have a system set up that way. So that's important, and you could say, well, okay, that is important, so we should start working on that, and we can work on it this year, and we'll do some of it this year and some of it next year, and we'll get through this, and we'll change the system gradually. But the other driving piece is this very different economic environment. We're in a 2% environment, which we're not used to. Healthcare has been used to 12, 6, 8, whatever, but not 2%. And 2% translates into 0 for hospitals, and in our Southeast Lynn, less than 0 for hospitals, and 4% for the community. But the 4% isn't cost of living. The 4% is targeted to specific areas that will help us address the higher issues. The point is, cost of living is increasing at 2%. Hospitals are getting 0% or less in our case. This turns up the heat and says that, yes, we need to respond to this, but we can't respond to it over a 3-year period or a 4-year period or a 5-year period. We have to respond to it today, right now, because that economic environment, the economists tell us, will not be 2 or 3 years. It could be 5 or 10 years. So this is a real situation that we have, and there's never been a better time to change and improve our healthcare system. Recently, as you know, we have a new government. We have a new premier, really, elected with a majority government. We have a new minister. We have a new deputy. Every time there's a change, that type of change, there's a mandate letter given from the premier to the minister of each of the various ministries. And in this case, this is the first time I remember, they've actually been published. So they're out in the open. All of you can read that letter. If you don't have it, it's probably on our website, although I should be careful saying that. If it isn't, it should be. But we can get you a copy of that letter. And that's a letter from the Premier to the Minister saying, this is what thanks for taking on the job, and this is what I expect you to accomplish. Then that becomes the direction to the Deputy Minister about what needs to be done. And I can tell you, we have a new Deputy Minister, and I've been fortunate to be in 6 meetings where he's been speaking recently. 4 of them were with the 14 LHIN CEOs, and 2 of them were in other provincial committees that I'm involved in. And he is a very different individual than past deputies. This individual is really engaged. He wants to understand what's going on. He may have been a CEO of a teaching hospital. He may have been a specialist, but he also was a primary care doctor. He is very interested in the community, very interested in how we change healthcare, and he wants to hear from people. He doesn't have it all in his head. He's trying to learn. In fact, he's made a point of scheduling 14 meetings in the 14 LHINs. So he's taken this mandate letter from the Premier to the Minister to identify these 4 areas where he's planning on focusing. Integration and coordinated patient-centered care. The term integration isn't a flash in the pan. It is as real now and probably more important than it's ever been. And LHINs are 10 years old almost. And the local health integration network, that wasn't a fad at the time. This is a term that talks about system. And so he's very concerned that we don't have a system and we need to get moving. We need to increase the pace to integrate the system. Increase in wellness and health and wellness and protecting vulnerable populations. Funding reform and quality improvement. The funding reform is something that's needed. I'll talk about that more, but it's tied to quality, and it's important to understand that there's some experts like Clayton Christensen from Harvard who said that the American healthcare system, most expensive healthcare system in the world, could continually drive down costs while constantly improving quality. They could get costs down, he argues, by 50% and still improve quality. The point being, you don't have to buy quality. We have a lot of resources that we should be using to ensure we have quality. And then this right care, right place, right time, redesigning home and community care, that's a big issue now. There's, with a 0% in hospitals across the province, need to invest in the community, and investing in the community means that hospitals are moving patients out earlier, and hospitals are moving patients out that are a higher acuity than what the patients were before, and we need to have a different response than what we've had. So this is a huge issue. They've established a panel that will be reporting to the Minister in January, so this is a quick time frame, and it will change probably quite significantly home and community care. In this area, he's also, and also the integration piece, he's talked about a number of the issues that we're addressing. So if you went through that list, you would find that he's actually talking about those issues. And in fact, in a recent meeting, he was talking about addictions and mental health. And he said, you know, we've got to do something to improve addictions and mental health. I tell you that there's no data. There's inconsistent collection of data. There's inconsistent ways that people access the care. There's no coordination. And the data shows us, the hospital data shows us that there's huge readmissions to emergency departments for addictions and mental health patients. All the things that you and the numbers identified that caused us to put addictions and mental health in our integrated health services plan and then become one of our strategic issues that we dealt with in the last 2 years. So how do you begin to transform the healthcare system? We're very set in our ways, and it's, you know, lots of times we fussed around the edges or tried to address a burning platform by watering the edges. Just touching the edges will lead us to mediocrity and will not improve the system. People are uncomfortable with change. We get that. We understand that. But to achieve improved access to high-quality care, taking this system that we have now to respond to the population appropriately within this economic environment, we really do need transformational change and disruptive solutions. So it may be uncomfortable, but we have to do it if we're going to use that $1.1 billion to the best of our ability. So the integrated response, a goal to improve access to high quality care. Our strategy is to build regional systems of integrated care. And when we're talking about integration, it's in different forms. And as I've said to other groups, I'm not sure how to draw this yet, but I'd like to be able to draw it or sculpt it or something. But we're talking about horizontal integration and vertical integration, and not separately, but coming together in a matrix. So horizontal integration is 7 hospitals working together across the Southeast, or all primary care working together across the Southeast, or all of addictions and mental health working together across the Southeast. That's horizontal integration. So sectors working together across the full range of the Southeast. The vertical integration is in sub-areas of the region, such as in the Quinte area, or the Brockville area, or the Perth Smith Falls area, and it's linking hospitals with addictions and mental health, with long-term care, with primary care, etc. And what you want from the horizontal integration is a consistent approach to access these services so that the vertical integration can link better this way. And so it is a matrix. It comes together. Again, I don't know how to draw this yet, but if you think of primary care people in Brockville should be able to access addictions and mental health services the same way a primary care professional in Belleville accesses addictions and mental health services. And so that starts bringing together a consistency. With consistency, you have less variability. With less variability, you have the opportunity to improve quality and decrease costs. So that's what we're trying to do, build regional systems of integrated care so that we'll improve access to high quality care. So Darwin didn't say it's the strongest of the species survive. He said it's the one that are most responsive to change. So your ability to meet change and address change and respond to change. And so if you're responsive to change, you're able to be strong. So that's what we're looking at in trying to move forward with our integrated healthcare system. And if you've heard me ever talk before, you know that I always show this slide. And I think this slide really lays it out. Here are a whole bunch of icons showing units of capacity. So whether it's addictions or mental health or family health teams or long-term care, community health service centers, these all show units of capacity. And they're clustered around where the populations are. Brockville, Kingston, Belleville, some throughout the rural areas. So it looks pretty good. But we have $1.1 billion for these 124 areas plus the 15 family health teams. But if we're in a 2% environment, what we really need to do is stop the way we've done it always in the past, has always been looking at where do we put new money. I got a new idea, where's the new money? Now it has to be, I got a new idea, where do I move the money from to get to this, to fund this new idea? We need to get more out of this $1.1 billion. And instead of looking at this as 124 or so individual units of capacity, we have to look at this, what capacity could we build if these 124 units were working in some systematic, integrated, collaborative fashion? So we've got to improve the ability of that capacity to meet the growing needs in our community. Our community isn't growing fast as far as population, but it is growing fast as far as aging, and that is changing the demand in our area. So I'll go through that list, and I'll try to do it fairly quickly. Quality. So that's a provincial initiative. The Excellent Care for All Act is reported to be one of the best pieces of health legislation that's been put forward in Canada for some time. Other provinces are recognizing that, and it really builds a commitment by the government to improve quality, again, within a 2% environment. I should say that in that 2% environment, health is growing by 2%, but we can't argue that, woe is us, we only get 2%. Education, I think, is growing at 1%, and all other ministries are shrinking, are staying the same or shrinking. So other ministries are supporting health. So we have no right to say, woe is us, and give us more money. So within a 2%, we're trying to improve quality. It's a very significant piece of legislation. Quality standard metrics, targets performance. There's developed Health Quality Ontario to really help give advice to the, not just to the ministry, but also to the many providers to ensure that they're understanding quality and they know how to move with quality, and they understand concepts like lean and other concepts that can really identify how we improve quality. And even CEO performance is now tied in many organizations to quality, and eventually CEO performance will be tied across the board to quality. We're trying to improve access to high quality care. It's our commitment. We want all patients to be safe. But quality isn't only the interface between the patient and the professional, because when we talk to the patient, they typically will say, you know, the quality's pretty good when I deal with my doctor or my nurse or whoever. It's not strictly about the interface between the patient and the organization. So when we talk about the community health center or the hospital, the patient will typically say, I had pretty good quality. But when you ask them about the quality they get from the system, they do say that that's bad, that it's a terrible story, that I go and I repeat my story, or I go and they weren't ready for me, or they didn't know that this other organization was referring to me, or the tests weren't ready, or whatever. They say, I have to manage that, and I'm already stressed with my illness, and you're, as a healthcare system, not helping me. So that's a big opportunity for us to improve quality. It's not just how quality is provided within the interface with the professional or the organization. It's also the system. That's an important part of quality. Not everybody understands that, but here's a great opportunity when we talk about organizations working together to realize this is part of the quality agenda. Funding for hospitals. There's a long history in this province of funding hospitals by everybody's got a global budget. You've got a global budget as one hospital. You've got a global budget as one hospital. You've got a global budget. You're efficient. You're inefficient. You're growing. You're shrinking. You all get 3%, 6%, or 12% like it was a few years ago. That's how we funded hospitals. So that meant that if you're inefficient, you were rewarded. If you're efficient, you were penalized because you got the same as they got. If you were growing, it didn't matter. If you were shrinking, it didn't matter. Now, there was an adjustment for growth at the end, and I think it was 2 years retroactive or whatever, but it really wasn't, it didn't meet the total growth, and it really wasn't truly a growth funding formula. It made an adjustment, but it wasn't a big adjustment. And so what we were doing was allowing deficits, and we were bailing people out. And in fact, it was very clear, a strategy, run a deficit, we can get more money for our hospital. Because typically the ministry, no matter how many times they said, no more bailouts, they would bail them out. And those CEOs who convinced their boards into, look, at this time the ministry's serious, we need to balance our budget, often got burned because the hospital down the street didn't take that strategy, and what would happen is they'd get bailed out. And then the CEO of the other hospital would sitting there in front of the board and say, well, I thought they were serious. We just lost an opportunity for some extra money. That's not a way to run a business. And healthcare, as much as it's a social and moral enterprise, it's also a business. It's not the way to run a business. So a new approach was needed. Everybody, you know, anybody who worked in a hospital, and I bet Bev and Ray and others have been on funding formula committees before and saw a lot of work done and a lot of analysis and a lot of prescriptive analysis that tried to identify or predict the future, predictive analysis, that's what I was trying to say, and it never went anywhere. They weren't implemented. So now we have a funding formula called the Health Services Funding Reform, and it rewards needs and performance. So it's focused on service needs and performance. New funding divides hospitals into 3 categories. Instead of just global budgets, you have a global budget which represents 30%, an HBAM budget, health-based allocation methodology. It's an allocation methodology, and that will represent 40%, and then QBP, quality and performance on certain procedures, which will represent 30%. The population needs, or the health base, is not saying that this is how much money is needed in the community. It says that based on the pie, or the amount of money that's available in the province, this is how much your share should be. It's not to grow the pie, because the government doesn't have that money, but this is how big the pie is. Therefore, the needs base tells you what your share is. So what this tells us is that in the QBP, in the HBAM, you will, someone once described it to me as a spreadsheet with 13 million rows, one for every patient in Ontario, or one for every member of the public in Ontario, and then columns such as age, sex, utilization, income, all that type of stuff goes way out. And then you can start determining how your hospital spends the money compared to peer hospitals, and look at an expected cost for that particular procedure compared, or for that particular patient, sorry, and compare that to what your actual costs are. And where you have actual cost that's higher than the expected cost, you lose money. Where you have an expected cost that is higher than your actual cost, you can gain money. So it's really important that you're always driving down costs. But don't forget, quality is embedded in this, so you don't drive down costs at the risk of quality. And the thing is, though, that this is being done by all hospitals, including those hospitals that are already efficient and high performers and have expected costs higher than actual costs. So that means that someone that has actual costs higher than expected costs, even if you do quite a bit of work, if every other hospital in the province is doing the same thing to drive down costs, then you may not get below the average, and therefore you could still lose money. QBPs, the quality-based procedures, and they started with knees and cataracts and a few other services, and they've expanded it, and they continue to expand it each year. There's an expert committee, expert panel of people who understand that procedure and look at what best quality, what's the best standards, what's the cost associated with that. And again, there's an expected and an actual cost, and you get the quality plus the price point times the volume, and that tells you how much money you will get. And so your opportunity then is to improve that price point, improve your cost compared to that price point. The problem is that if you have small volumes, then it's very difficult to get your price or your cost below that price point. So, and you have to, quality is embedded in this, so you cannot compromise quality. In fact, you have to be improving quality. And this is what it looks like. There was 3 years identified for mitigation, and this part was going to grow and change the balance from global to QBPs, global, and to eventually get to this 30, 30, and 40. They added an extra year for mitigation. Mitigation was to prevent any hospital from losing more than 2%. But after the end of 3 years, and now they've adjusted it to 4, so we're in the 4th year, once that is over, the mitigation is gone. And if a hospital hasn't responded to this and really looked at its cost structures, then they're in trouble in the subsequent years, because there will be no more mitigation, and those expenses could be big. What does this mean in the Southeast? We're negatively affected, more so than, I would argue, than any other LHIN in the province. As a proportion of the money that we lose compared to all the money that is spent on hospitals in this area, we lose the biggest proportion. The number of hospitals in our area compared to the number of hospitals that lose money compared to the number of hospitals in our area is greater, that proportion is greater than any other LHIN. So 5 of our 7 hospitals this year lose money, 5 of our 7 hospitals last year lost money, even with mitigation, and those aren't the same hospitals actually. Some of them were, but not all of them. And in addition, the amount of money will be quite substantial. We're talking tens of millions of dollars coming out of our hospital system. And so this means that, again, we have to be looking right now, today, and not tomorrow, to how we address this. Primary care. And I've got some really good feedback, and I've got to be really careful. Two pieces of feedback I received recently is a doctor told me, actually this week, Paul, every time I hear you speak, I understand that you're talking about a single hospital in the Southeast. I said, what? How could you possibly get that from anything I've ever said? I am not, and I'll make that perfectly clear, I'm not talking about one hospital. I'm talking about 7 hospitals working together in a regional system of integrated hospital care. You don't need to amalgamate to do that. Some cases you do need to amalgamate, but you don't always have to amalgamate for integration. We need integration. The other thing is that I got the feedback that when I talk about primary care, what do I mean about primary care? I mean all of primary care. So primary care physicians are part of primary health care, if you will, and we have nurse practitioners that are a part of primary health care. We have other members and other professionals that are a member of primary health care. We also have different types of organizations. There's something like 4,000 primary care entities in the province of Ontario, and that could be a family health team, a community health center, a family health organization, a nurse practitioner-led clinic, a solo practitioner, and other models of primary care. And that's okay to have those different models because certain providers want, our professionals want a different model, etc. But they are different, but they're all part of primary care. So at the moment, most of primary care is not accountable to the LHINs. Community health centers are, but the rest of primary care technically are not accountable to us. And so our mandate is to integrate the system. That's what the government tells us, that's what LICIA tells us, LICIA being the legislation. But a large part, probably the part that has the biggest touch points for patients other than community health centers is not accountable to us. So it's really difficult. So we've been talking to the government about the full integration, and there is some movement on that. From day one, we had 2 physicians, primary care doctors, put myself in the chair, the then chair, up against the wall and said, you know, we're not accountable to you, but you have to work with us. So we said, okay, we'll do that, and we established the first primary healthcare forum. Out of that, there was direction to create a primary healthcare council. That was back in 2007, I guess. And since then, we've had 7 primary healthcare forums, and we've built this relationship with primary care. So when it came time to start looking at how we actually move primary care into the discussions about integration, we had a good relationship with primary care. And we've been engaging primary care professionals from day one. We've actually been a driving force for the ministry to get primary care physician LHIN leads in each of the LHINs. So we have an individual physician whose responsibility is to engage primary care physicians to help us understand what could help them. And we're talking about primary care physicians in every model or every type of entity. So the question is, will the accountability for primary care come to LHINs? Most likely through primary care, healthcare, health human resource planning. So that it's been clear that that's going to happen. We've been given that responsibility, and we're starting to work with the ministry to figure out how we actually roll that out. Accountability for quality targets. The ministry has also said now that you will have that accountability. We also have indirect accountability with Health Links, through Health Links with all primary care, and I'll talk about that in a moment. And then it is quite possible that we'll get full accountability for primary care. Primary care is essential. My way of thinking, and you know, I certainly appreciate that some people would disagree with that, but if I'm a patient and I want someone to have the big picture of my healthcare needs, I don't want that in the hospital, and I don't want that in a long-term care home or a CCAC or addiction mental health. I want that in the primary care office. I want them to have the big picture of my healthcare needs. What if I'm taking vitamins that are counterreactive to certain medication? I want my primary care doctor or I want my primary care office to understand that. The big picture needs to be there. So to us, this focus on primary care is something that we've had from day one, and I think it's helped the Southeast area a great deal. And we have great examples where family health teams, including in this area, where family health teams work well with community health centers, and family health organizations and nurse practitioners, and the whole health links couldn't have moved better in the Southeast if we had not done this with primary care, if we had not built this relationship. So to transition into health links, the minister some time ago said that the previous minister, Deb Matthews, before the previous election, not the recent election, said in her action plan for health that primary care would come to the LHINs. It didn't quite happen, but as soon as that was mentioned, and then recognizing also that this group called ISIS, not the one we know in another part of the world, but ISIS, the Institute for Clinical Evaluative Sciences, they had done some looking at these 4,000 primary care entities across the province, and they recognized there's some natural groupings of these. Understand, these entities, even though they might be blocks away from each other, really didn't work with each other. So you could be a primary care entity, and you could be a primary care entity. You being a community health center, you being a family health team, you might have a diabetes educator, you might have a nurse practitioner. You never, ever shared those. You never even talked. We had doctors telling us, well, I don't even know who the people are in that office across the street. So all these entities didn't work with each other. But ISIS did some analysis and saw there were some natural groupings. From that, we took it and created a model that we thought made a lot of sense based on those groupings. Everybody was creating models for primary care when the minister had let out this action plan. And they accepted a model that was most built on, and they tell me it was most consistent with the LHIN model that was presented. That's what they tell us. And so health links became a reality. What we did was take the ISIS data, we went to, we analyzed the data further, we drilled down further. ISIS data said there should be 4 of these groupings in the Southeast. We drilled down further, we laid on top of the analysis distance and income and some other things, and came up with 7 different geographic areas. Then we went to the physicians and said, what do you think about this? The physician said, makes sense, the number, but we think the lines on the map are wrong, so we changed those lines to meet their advice and created the 7 health links that cover the entire geography of the Southeast. There was criteria with the ministry, had to have 65% of the doctors in that geographic area to become a health link, to be approved. We're the first LHIN to have all our health links approved and also operating. So there are others that have gotten them approved now and some others that have their geography covered, but not all of them have both of that. So we're ahead of the pack, and again, this is because of the good relationship that had been developed. And that was move it along. So this was, see, you caused me more time to lose my spot. So this was important because we were able to move the health links quickly. And health links are currently focused on the complex patient, the 5%. But we know that there's a whole nother group of population that's waiting to become that 5%. And so we need to also address that population, and eventually health links will cover the entire population. So in other areas, we know that there are some problems with health links. We know that they don't have the 65% of the physicians. We know that some are led by non-primary care, and in our LHIN, all 7 are led by a primary care entity. And we know some other problems that are going on with health links elsewhere. We really are, in probably many ways, the poster child for health links in the province of Ontario. And I've had colleagues provincially say that to us. So here are the 7. These are the geographic areas. This is what a health link actually looked like. The only reason we put the 2 circles in here was to separate, not that they are, but to separate for visual primary care from non-primary care providers. So in the Quinte Health Link, I should have brought one of the ones from this area, 4 family health organizations, 2 family health teams, nurse practitioner-led clinic, community health center. So those are the primary care entities that need to work horizontally with each other and who didn't before. And then the vertical integration with the Southeast Collaborative, the CCAC, Quinte Health, Public Health, VON, addictions, etc. And so that's what a health link looks like. and they develop then coordinated care plans. They'll be measured on these type of metrics. I won't go through this. You'll be able to get access the slide deck and look at this, but we'll actually be evaluated. We're doing a Southeast evaluation that won't be as in detail as that, but the province will be evaluating with the concept of health links. I can tell you the minister in his mandate letter to the deputy, or the Premier's mandate letter to the minister said very clearly, health care is our initiative. We are going to continue to evolve that. I can tell you the minister has told that to the deputy. The deputy's made it very clear health links is one of our priorities. And the ministry said, we didn't know how fast this was going to grow. We love health links. We want to own it, but we can't. It's all the LHINs. So the transition is totally to the LHINs. Every health link is accountable to a LHIN. And it doesn't matter whether they're a family health team that's a lead or a community health center that's a lead. Every health link is accountable to the LHIN. So indirectly, we can fund actually a family health team this way. There are some policy issues that the ministry has to overcome, but understand that if you're not a health service provider as defined by LICIA, the act, the legislation, such as a family health team, we can't give any money to that family health team. We get 4% money in the community to invest. We can give money to a community health center. We can't give money to a family health team. So that's why it's important for us that there's this accountability. Indirectly, we have accountability through health links. And one of the things health links are doing, they've approved, they've covered the entire region. We have 75% or more primary care physicians in each of our health links. One has almost 100. We have a reduction in untapped patients. One health link, I think, has driven that down to 0. Complex patients have been identified. That was a challenge. How do you identify complex patient? Over 500 coordinated care plans are implemented. We expect to have 1,000 done by the end of this fiscal year. And those with coordinated care plans have less acute care admissions. These are ad hoc reporting that we have, not formal evaluation, and fewer ER visits. Patients are also reporting high satisfaction that I'm actually involved in my care plan. I'm actually telling them what's important to me beyond strictly the health care. Addictions and mental health clients told us that it was difficult to gain access to addictions and mental health service, that when they did, the programs were disjointed, they acted independent of each other. Data was limited and inconsistent across the various providers. Hospital data told us that ER repeat visits were high and steadily increasing for these patients and clients. Significant proportion of ALC, alternate level of care patients, also needed AMHs. So we started off by talking to the client. And patient-centered care, if you remember that first slide I showed you, Bob Bell's interpretation of the mandate letter, in the center was the patient. And so we talked to the patient, and actually we're sort of ahead of the game on this. And when he was talking about, when Bob Bell was talking about addictions and mental health, this was just a few weeks ago, and we'd all been at this for almost 2 years. The ADM leaned over to me and said, that's why I've been telling Bob, we've got to go down and see what the Southeast is doing. You're right on with what he's thinking about this. So we focused on the patient experience and built this model, identified what are the basket of services, common basket of services that should be delivered across all addictions and mental health services, identified that, and then only that, and that took us over a year to do, and then only then did we say, do we have the right governance in place to achieve this? And the conclusion was, no, we didn't. And I can tell you one example was one day I had an organization come into my office and say, look at Paul, we understand what's going on, et cetera, but if you did it our way, it would be the right way. Everyone in the region should do it our way. I said, okay, thanks for that. Within 2 hours, another organization came in and said exactly the same thing to me. You know, this wasn't scheduled, this wasn't arranged that way, but they did things totally differently. So the point is, they weren't communicating with each other and they weren't looking for the best way. So we did undertake this. The plan is approved. The focus is on improved client journey, common basket of services. Providers are working on implementation plans right now. A regional strategic alliance will ensure that we have consistency across these new organizations, and regional programs will be better linked with the 3 new referring organization. So for a hospital, whether the hospital is Brockville General or whether it's Quinte Healthcare, they'll be able to access addiction to mental health services the same way. So this is a major step and a major effort, and it is consistent with what the deputy was saying the other day, and we're hoping that they'll take a look at ours and give some advice to other geographic areas. Hospital sustainability. So I told you about the funding formula. Probably should have ordered these a little differently. The 7 hospitals do not work as a regional system of care. So we see Kingston in gridlock all the time. And so as soon as they're in gridlock, then there's a discussion with other hospitals to move some patients out, et cetera, but it's not working as a system. The impact of the health services funding reform is very significant, requires immediate change. So the 7 hospitals, the CCAC, Queens Health Sciences, and the LHIN are undertaking a major planning process, and that's been underway now for about 3 months. We're just gearing up. We've had an RFP out, and we've got a firm helping us. We have a visioning day tomorrow. We're really trying to look at how we get those 7 hospitals working together. So we have the board signed off on this, the COs signed off on this, and what we want to do is create a regional system of sustainable quality care. So what will be done in this process is confirmation of the impact of the HSR. How much money do we think our system is going to lose? And this isn't one-time lost money. This is out of the base. So our base will be moving from here to here. So how do we provide hospital care? So we've got to confirm what that impact is. Then we're going to review what each hospital is doing as far as improving administrative efficiencies. And then we're going to look for opportunities for joint administrative efficiencies. If we want every dollar we got going to patient care as much as we can, do hospitals really need to hold on to their payroll system? Do they really need to hold on to their IT maintenance system? Is that so important that you would jeopardize patient care? I don't think so. What are the opportunities for clinical diagnostics and lab services? So are there opportunities to run a regional system? So I guess that's maybe, when I say those type of things, I guess someone could say, you're talking about one hospital. I am not talking about one hospital. The 7 hospitals already have 3SO, which is a back office for supply chain management, and it has delivered beyond what the business case suggested it would. And then we get into the real difficult issues, reconfiguring clinical services. So how do we do that? We said that there'll be 7 hospitals today and 7 hospitals tomorrow, even 11 sites today and 11 sites tomorrow. So how do we do that? How do we reconfigure clinical services? Well, we need to recognize that, for the volume of hips and knees that we have in this province, are in this region, we have 5 providers of that service. Do we need 5? So maybe we do, maybe we don't. We'll do the analysis that tells us. But then when we do that, then we'll also be saying, okay, well, if there's a movement, then what goes to an area that doesn't keep providing that service? Because we said 7 hospitals today, 7 hospitals tomorrow, but we're talking about viable hospitals. So it's not just looking at this one-off. We have to look at the whole picture of clinical services. This will be tough, but it will be clinician-led. And we have a 12-month timeline, and the implementation that will improve access to high-quality care. Assisted living, I'll go through these quicker. Assisted living, we were the only LHIN that when LHIN started that had no assisted living. And we were thinking, assisted living, how do we get a handle on that? We've got to get builders to build apartment buildings and other structures for us to provide assisted living. But then we learned more as people told us, don't worry about that, just find out where seniors are clustered and then look at building this assisted living into those programs. So we've worked through that. We've identified 3 pilot areas in Brockville, Kingston, and Belleville. We're initiating those. I think they've been initiated actually 2 weeks ago, and we'll learn from those experiences. We'll learn what type of patients require this and the impact it has on hospital admissions and other metrics, and then we'll roll this out as a more comprehensive strategic plan for assisted living. Acquired brain injury. We had very little residential units for acquired brain injury. We had a very high-profile family with a lot of energy, who were very concerned that they were aging and their adult child with brain injury was also aging, but they were worried that they were going to pass away and no one was going to take care of this client and this son. And so they started talking to us, embarrassingly, a while ago, and just now we've been able to move because there was a lot of moving parts to this, but we will be opening in the spring a bungalow with 6 units in it, and then we'll be opening an apartment later in the year with 6 units in it, and we'll have an opportunity to place clients in an acquired brain injury service provided with the care being provided by Pathways for Independence, and hopefully that will have a big impact not only on these clients but on their parents. Community support services, there's a lot going on in community support services, and we do have the home and community care panel going on. One thing that this pressure on hospitals has led to, this financial pressure, means more and more patients are coming out early. They have higher acuity. CCAC, we've asked them to take up this piece. By doing that, we've invested money in it, into the CCACs, but they're high level. They're not just getting a higher volume of patients, they're also getting a higher acuity level. So we need other services to come into play, and community support services have an opportunity. But we just don't have the bandwidth to be doing a strategic plan for community support services yet, but we do have some priorities that they have identified, and we're focusing on those priorities right now with them. I should also say that with the hospital sustainability study, there'll be times that we look at certain services and say, you know, this service should not be in the hospital. And then we'll go to Health Links or CCAC or community support services and say, do these patients make sense in your service area? And if so, how would we do that? And we would gauge them and get ideas and come back and then start adjusting and then go back and engage again and say, what do you think about this option or this option? CSSs will also be involved in that. So right now, CSSs are looking at the various priorities. Hospital information systems. We have different systems, and one of the big issues that we know about integration, if you really want to integrate programs so that you improve patient care, you need to enable it with information systems. We're the industry behind the 8 ball on this. Other industries, you name it, have done this much more effectively. There's always roadblocks, there's always challenges, there's always a reason to delay. Our 7 hospitals have come to an agreement that we will send out a single RFP for a new platform for the 7 hospitals. And you can imagine we have a big hospital like Kingston General, and we have some very small hospitals. And for all of them to come together and work through this process to come up with a single RFP that should be ready for release in, Steve, you probably know, February, I think we're talking. So that's a big, big step, and again, a good model for other parts of the province. Data center, this is more internal. I made a point from day one saying to the ministry, when they gave me an organization chart saying this is what your LHIN should eventually look like, I said, well, this is just a guide, right? And they said, no, that's your chart. And I said, well, not really. And they said, well, what's wrong with it? And I said, well, you don't have an epidemiologist on it. And they said, well, why do you need an epidemiologist? And I said, if we're going to do local health system planning, we got to be quantitatively skilled. And they said, well, you can ask us for the data. And I said, there's no way I'm standing in line for you to determine whether or not you accept my request, and there's no way I'm going to stand in line waiting for you to decide if you accept the request, how long it takes you to get the data to me. And they said, fine, go ahead. So we've developed a very strong knowledge management team, and in the early days, a lot of providers used our data and gave us feedback about that. So we've worked now to build a consistent data center that we will have licenses for every single health service provider in the Southeast. And you'll be able to access that, and there'll be data that's analyzed, and there'll be some not really raw data. All of it will be analyzed at some point, but it will be very beneficial to you and your organizations in developing your own strategic plans as you try to determine how you fit into this integrated health system that we're trying to create. And then the last point, another enabling piece, is leadership. In the early days when we were talking to hospitals, we'd say to a hospital, here are some regional priorities that we need to address to bring down ALCs, alternate level of care patients, or to decrease the dependence on emergency departments or whatever. And we would get feedback, Paul, you're asking us to look at these regional priorities, but we've got our own priorities. I report to my board, I got my own priorities. And I would argue, well, these regional priorities will help you with your own priorities. And they say, yeah, but you know, I have this obligation to my board and these are my metrics. So I thought, so how do I get people to think beyond their own organization? Then when Health Links started to develop, we had people come to us from Health Links and said, you know, we are skilled clinically. We know clinical. We know how to provide services within our organization, and we do a good job on it. You're asking us to build what basically is relationships. We really aren't skilled in that area. So we thought about this and sat down with the Rotman School of Management. We know that we have great leaders. We have visible leaders like board chairs and CEOs. Everyone, I mean, we have some of the best leaders in the province, in the Southeast, and therefore I would say we have some of the best leaders in the world existing in this region. And some of them are visible. Some of them are EDs that are in this room right now. But some of them are the ones that aren't visible. They're frontline people who really have the interface with the patient, and they know what's not working for the patient. We have well-led organizations. But what the system needs is system leadership, system leaders. Leaders who see the role of their organization in improving the system, who see beyond their own organization, leaders who define common standards, leaders who understand complex needs of the patient. We need leaders who understand that the system has more to offer today's patient than any one organization can. Understand that only when an organization works with other organizations, pursuing common vision and developing, resolving variations in care protocol, can we truly be responsive to the needs of our patient. And we need leaders who know how to build relationships necessary to facilitate organizations working together to meet the needs of the patient, requiring multiple services from a continuum of care. So in 2014, this year earlier, we worked with Rotman, we ran the first program and graduated after a 10-day course, 5 months of 2 consecutive days, 45 learners who are now graduated as system leaders. The program is called Advanced System Leadership, and we graduated the first 45 system leaders. We are offering another, we had 96 people apply, so we're offering another program starting in November, another 45. We got 76 people apply this time, so we'll be offering another one later. We'll graduate the one that's starting in November sometime in the new year, and then we'll offer another one. What we're looking for is people who are striving to be system leaders, who want to stand up and say, you know, we want to contribute and we want to drive the change in this as an overall system of healthcare. We are leaders, and so we're looking for people, and we're giving them the opportunity to train. I don't know if anyone here, I just saw the list last night, so I don't know if anyone here was on that list. But some of them have been already, and so we're going to graduate another 45. We think this will be another enabling factor for us to achieve an integrated system of healthcare that will improve access to high-quality care. So I'd be pleased to, yes. So all of this, what should we expect out of it? Well, we should expect to see a health system that's integrated and functions as a system, one that responds to complex needs of our patient, one that provides access to high-quality care and provides care in an environment that's safe for the patient and the staff, one that provides this type of coordinated care within the financial means available, and also this should lead to lower wait times, lower repeat visits to ERs, should lead to fewer ALC patients, greater patient satisfaction, and also greater staff satisfaction. So that's what the committee asked me to speak about. That's our agenda.